So, greetings from Artemis Hospital, Gurgaon. So, today we are going to discuss a very important topic in neuroanesthesia course. It's about anesthesia for neurointervention. Now, neuroradiology is actually the upcoming field in neurosciences, I will say. So, a neuroanesthetist should know the finer details of intervention neuroradiology. Now, if we come to the definition of what is intervention neuroradiology, this is what I get best in the literature. It is actually the discipline that uses endovascular procedures to treat vascular conditions of CNS. So, what actually intervention neuroradiology has done? Intervention neuroradiology right now has made it possible to go endovascularly in those procedures which are previously been thinking that we can't treat those patients, or a craniotomy or a surgical techniques are necessary in those patients. So it's basically a replacement for vascular surgery, and sometimes there is very difficult to approach some lesions like some blister aneurysms in vascular surgery as well through open craniotomy. In those lesions as well, intervention neuroradiology is coming out to be as a boon. Now, coming to the indications. Now, indications are actually being expanded day by day, from coiling, or I will say putting flow diverters to aneurysms, to stent assisted coiling, to balloon assisted coiling, to AVM embolization, tumor embolization, mechanical thrombectomy. Mechanical thrombectomy now is actually a class 1A evidence to do in acute stroke, sclerotherapy of venous angiomas, carotid artery stentings, so on and so forth. I will say that every day I am going to find a new indication of in neurointervention lab, and sometimes in neurointervention lab you are assisting bleedings of other specialty as well, like for angiofibromas of ENT you are embolizing the tumor. Sometimes the bronchial artery vessel bleed, you are helping in glue embolization of those vessels which are being bleeding acutely. So it's sometimes in emergency it's life saving as well, but it throws many challenges to anesthetist as well in terms of remote location. I will say the location of DSA Lab is far from the OT, sometimes on the same floor, sometimes on a different floor. You are lucky if it's on the same floor. There is restricted area of work, restricted and I will say a dark area of work, and freezing temperatures. So patient and the anesthetist as well are hypothermic at the end of the procedures. So there are many challenges which we are going to discuss in the coming slides. So coming to the goals in intervention neuroradiology lab. So apart from the usual goal of maintaining the CPP, the most important goal in DSA lab is treatment of complications. Now, treatment of complications, I mean, is that the complications, it's actually been procedure specific, but largely you can divide complications among two things: the hemorrhagic complications and the thromboembolic complications. And early interventions in those complications is the key to the final outcome of the patients. Apart from that, management of anticoagulation, that is heparin, intraarterial antiplatelets, which we usually give, radiation protection. So these are the things which you are subsequently going to discuss in the slides. So that's what already I have enumerated. You can actually divide the complications into three parts: the CNS part, the hemorrhagic thromboembolic, the non-CNS part, that is contrast induced, puncture related, like groin hematoma, retroperitoneal hemorrhage, anesthesia. So remote location we have discussed, anticoagulation related, so bleeds and all those things, or a thromboembolic complication again, and to reverse heparin and all those things comes under complications related to anticoagulation. So first I will come to the radiation protection, because your safety is paramount. So you and your staff or your technician safety. So if I will say, what are the sources of radiation? What are the sources of radiation in a DSA lab? So it's a direct radiation from the X-ray tube, leakage through the collimators, that are the protective shieldings, and there is a scattered radiation from patients during the procedures. Okay, so this is basically a list. If you see that list, if you look at the list in the intervention cerebral angiogram, it's about 300 to 500 X-rays. So it's a lot of radiation. But if you actually manage it safely, the overall monthly dose fall way below than the recommended upper limit of the radiation. So most of the time, the clear communication with the neurointerventionist, the structure of the lab actually tells you where you have to stand, because you need to remember the inverse square law. The farther you are from the tube, the less is the radiation, and it actually decreases very promptly. And most important thing is the use of slave monitor. So there is one monitor which is inside the DSA lab, and the replica of that monitor connected to that through the wireless, or now the Bluetooths have also come. So it has been outside the NR suit. So the angiographies, or sometimes the non-critical steps, you can stay outside and monitor the vitals from the slave monitor as well. Okay. And I will just go to this the structure of DSA lab. If you can look at the structure of DSA lab, then you can see just a moment. If you look at the structure of DSA lab out here, so anesthetist actually stands on the left side. Okay, so their left side is the anesthesia workstation. It's actually behind their screen. So the photograph is not showing the anesthesia workstation, but I've just put it an arrow here. If you look at this arrow, this is the anesthesia machine behind the screen. And then this table actually rotates here, there, goes up, goes down most of the time. So anesthetists are mostly standing here. This is the lead shield which is there, and this lead shield is movable. This comes right here, and it's in front. It's kind of a barrier between the neurointerventionist. The neurointerventionist is standing here, and it's kind of a screen will come here. It comes as a barrier between these tubes and the neurointervention. So this lab is actually a biplane. You can see an A plane, you can see a B plane. So these plane moves in AP and lateral direction, and then they can rotate. So most of the labs in modern day technology are the biplane labs. Okay, so this also causes problem in terms of space, in terms of you have to maintain those lines, you have to maintain those tubes. So that's a pretty structure of those labs. So in terms of radiation, I will say this will come here. So the good position for anesthesiologist, if you just shift your monitor out here, somewhere like just laterally or on the left side from where it has been seen right now, you shift that monitor here, and then you can stand here. So you can look at the monitor at the surgical step, or I will say the intervention step, what's going on here, and then you can look at your monitor as well, and during the critical steps what's going on. Okay, so let's go back. So that's I think about the radiation. Now we'll come to the preoperative planning. Now preoperative planning, the first and the foremost thing is the blood pressure. Nowhere the blood pressure is so important as it is in the vascular procedures. So baseline blood pressure, I will say, is very important, because most of the complications which you are going to deal, you are basically fine tuning the blood pressure. So either you are increasing the blood pressure in thromboembolic complication, or you are decreasing the blood pressure in an hemorrhagic complications. So you need to know what the baseline blood pressure is, because most of the time you are manipulating the blood pressure depending on what was the baseline blood pressure of the patients. Most of these patients, cardiovascular reserves, if it's good that if it needs to be assessed either as well in every anesthesia checkup, you are going to check the cardiovascular reserves. Patient's previous experience with radiology imaging, so whether the patient has got a contrast allergy, whether the patient have received previously heparin, because sometimes HIT is easily diagnosable if the patient has been HIT means heparin induced thrombocytopenia. So it is easily diagnosable if you have those histories point mentioned already. And very important is the neurological deficit and current Glasgow coma scale should be mentioned in your notes, anesthesia pre-anesthetic notes. Symptoms of raised ICP, if they are there, should be noted: hypertension, bradycardia, pupillary dilatation, pupillary asymmetry. So these needs to be mentioned in the charts as well. Now one line about the EVD management. Now if the patient is on EVD, you should, as a neuroanesthetist, know whether you want to open the EVD during the procedure. You have to discuss it with the neurointerventionist, or you want to open it during the procedure. Most of the time the EVDs have been clamped during the procedure, but sometimes intraoperatively, when the brain becomes tight, there is a rupture of aneurysm and the EVD is in situ, it comes handy to you, and it's really helpful in those case scenarios. Okay, so this is actually very important. The history of renal impairment, so contrast has been used. So history of renal impairment is important. Urea, creatinine, renal function should be tested. Okay, and women of childbearing age, of course, a negative pregnancy test or confirm that they are not pregnant, it needs to be documented as well. So that's what we have discussed. So if you look at the anesthesia technique, I come to the anesthesia technique, I will discuss the generalized things first, and then I will go to the more specific things about the procedures. So if we discuss about the anesthetic technique, IV access and adequate large bore access is necessary in those situations, because when the catastrophe happens, you are in a soup if you don't have a good IV lines. That's true for every procedure. But this IV access should be with adequate extension tubing. And they're preferably in the left hand. If you look at this, you are standing on the left side of the patient, so it's easier, because the tube is coming from the right side, you need a more extension. If arterial line is coming from the right side, you need a more extension tubing. So that's pretty good if it's they are on the left side and being secured with large lines. Okay, most of the time vasopressors in and out needs to be done with AVMs, with aneurysms, so that's also been required. Temperature control is very important in DSA labs. So a patient is bound to be hypothermic in these labs. So, and most of the time you can put a oropharyngeal probe in these patients, but generally they interfere somehow with the imaging. So it's good to put a rectal or axillary probe in these patients. But even if you are not looking at the temperature, these patients are hypothermic. That's for sure. So this is very important cause of delayed extubations in DSA lab. The patient is hypothermic post-operatively. So another important thing which is different from when you are doing the things in the OT is a large volume of endovascular catheter flush has been used. So these catheter flush have been, these drips actually contain sometimes nimodipine. They actually contain nimodipine, or sometimes NTG, which has been given intra-arterially in the vasospastic artery, so that they are able to take their microcatheter, their catheters up from the arteries. So blood pressure also falls with these drips, and sometimes the drips have been given very faster. So there is a good diuretic effect, sometimes a hypotensive effect of these drugs. So you need to maintain a good pressure. That is why I told you vasopressors may be required during the maintenance of anesthesia in these patients. Okay, so arterial blood pressure. Now coming to the monitoring, arterial blood pressure, I will say is actually a must for all intracranial procedures. And sometimes if it's becoming difficult in these some kind of scenarios, you can take a side port of femoral artery sheath which can be used, but then you need to know that these sheaths are generally being removed post-operatively. So you tell the neurointerventionist that I'm going to use it post-operatively for at least 24 hours. So please remove it a day after if you really require it, or you change it to radial artery, especially in mechanical thrombectomy. If you're not able to put it at the time of emergency, you just take it from the side port, and then just when the procedure is over, put a radial artery cannula, and then they are able to remove those sheaths. Electrophysiology, people are using it, especially during the spinal AVM procedures. But I personally don't have any experience in electrophysiology in DSA lab, I will say. But yes, I have seen some videos. Some people are actually using it in those spinal cases. So that's it. Not commonly used though. So general anesthesia. So most important reason for why we give general anesthesia in these patients, these procedures are basically a pain-free procedures. So you require general anesthesia for immobility. So most important reason to give general anesthesia in these patients is to maintain immobility. So that immobility actually minimize the motion artifacts and it reduce catheter induced complications. Just see that if there's a catheter in C2 and the patient just moves its head here and there, then it's the neurointervention is just go haywire. If it's especially if it's in critical step of entering into the aneurysm or doing a glue in the AVM. So that's the reason why you actually prefer general anesthesia in these patients. Nitrous oxide is generally been avoided for a very lame reason that actually it expands if there is an air bubble, inadvertent air bubble in the microcirculation or in the intraarterial flush, then it will expand that bubble. So there is no clear cut I will say consensus on that, but if you are able to give that anesthesia without nitrous oxide, it's well and good. If you are used to nitrous oxide anesthesia, just switch it off if it's that kind of a catastrophe has happened in your neurointervention suite. So no clear-cut superiority, I will say, of one form of anesthesia over the other, but inhalational, I will say, is actually been technically easier. So no lines connected, no infusion pumps connected, so less of lines, less of cumbersome in that moving planes of DSA Lab. So it's good that you maintain it through inhalation. But if you require, you can use TIVA very easily. It's not much of a problem. And another reason is you are able to maintain those carbon dioxide levels, which you can maintain according to the procedure and patient specific considerations. So that's the main reason of going in general anesthesia. But sometimes you use MAC, especially in mechanical thrombectomy, which we are going to discuss in great detail, which is a hotspots topic as for DSA Lab. And whatever procedure you are doing in MAC, whether it's in OT, whether it's in DSA Lab, doesn't matter. You need to evaluate the airway, and airway evaluation should be done. Discomfort associated with injection of contrast into the cerebral artery. So when the neurointervention actually give a contrast, there is cerebral arteries burning. So most of the time the patient just moves his head like that. So, or he will say that there is severe burning sensation which is going on and there is a headache due to distension or traction on arteries. So this is their main cause of concern. Sometimes you need to give a dose of fentanyl, and there is a longer dose of longer period of immobility. So patient get restless if the procedure is taking longer than usual. That especially happens sometimes in tortuous arteries when they are not able to pass through the arch. I will never use a nasopharyngeal airways in these patients. So if you use nasopharyngeal airways in these patients, sometimes they result in catastrophic bleeding because these patients are on anticoagulants. Nowadays in stent assisted coilings and balloon assisted coilings, they use antiplatelets as well. So they never put those nasopharyngeal airways so that you can give deep sleep and then put a nasopharyngeal airway. That's not a very good practice. Dexmedetomidine has come handy in these procedures with us, especially I will say to those patients who are anxious and claustrophobic. So we are using dexmedetomidine in those patients, especially when one more thing which you need to take a very important clue from dexmedetomidine is that dexmedetomidine causes hypotension, and especially these patients, some of these patients, vascular patients, have been maintained on a precarious collateral circulation. So just see whether how much fall in blood pressure. So see again the blood pressure, the baseline blood pressure comes handy to you. So blood pressure has got a very significant important in this whole of the neurointervention lab anesthesia. Comes to anticoagulation. So heparin is generally administered intravenously to minimize thromboembolic complications and to prevent vessel occlusion. A baseline ACT is generally obtained, and then a bolus dose has been given, and then every hour the dose is being repeated. Some centers do use infusions of heparin as well, but in our center we generally give bolus dose of heparin as and when required, generally after an hour or so. But suddenly for a vascular aneurysm or a case like that, we generally wait till the microcatheter or the balloon has been placed, and then we will give a second dose of heparin after the first dose has been given as a bolus dose. So that's how you generally maintain and aim for an ACT of around 2 to 2.5 times the baseline. So from here I will come to the specific. So intracranial aneurysm coiling. I think this is out of the box when I'm recording it. Sorry. Just okay. So intracranial aneurysm coiling. I will say this is the most important procedure done in DSA Lab, and it will form the crux. It will form the 70% of the procedures which you are going to do in DSA Lab, whether in an acute situation like a subarachnoid hemorrhage, or sometimes now an unruptured aneurysms has been coiled, stent assistedly coiled, or flow diverters. So these diverters are another headache for neuroanesthesiologists. You need to understand them in great detail. So I have a separate lecture on that as well, but we are not going into details of flow diverters here. But yes, I will mention during the subsequent course of intracranial aneurysm coiling. So the basic principle, so we are not going to discuss anesthesia for aneurysm per se. So that's a separate lecture in the e-course there. But I will state away the differences what are there from the clipping. Okay, so as in clipping or as in wherever, intubation is very important. So you need to maintain a balance between a CPP, that's the cerebral perfusion pressure, that's the difference between mean arterial pressure and ICP, and the transmural pressure. So transmural pressure is again the pressure across the wall of the aneurysm. So there is a wall of the aneurysm and there is a transmural pressure. So the mean arterial pressure and the ICP is again there. So you need to understand this concept. So if I will say to you, so when you are doing an intubation, you are actually increasing the mean arterial pressure. So when you are increasing the mean arterial pressure, you are actually increasing the transmural pressure. And when you are increasing the transmural pressure, there is every chance that the aneurysm might rupture. Okay, so that's you need to handle with care. But at the same time, if you look at cerebral perfusion pressure, if your patient is going to hypotension, then your transmural pressure might be okay, but in your cerebral perfusion pressure is going down. So how to do this balancing act? So if your patient is a good grade patient, so a good grade patient means HNH grade, Hunter has grade 1 patients, or WFNS grade 1 or 2 patients. So those good grade patients in which the ICP is actually not being raised. So what you do, in those case scenarios, the brain can actually have a little bit of hypotension during induction. It can actually, I will say, tolerate that bit of decrease in CPP at that time. But if your patient is a poor grade aneurysm, then hypotension is certainly not warranted. And in a poor grade patient, especially the patient comes on a 4th or a 5th day, when actually the risk of vasospasm is also there, and at that time you are giving induction agents and it's causing hypotension, so you are decreasing the transmural pressure. So risk of rupture is actually decreased, but there is a decrease in cerebral perfusion pressure at that well in those patients. So you just need to do those balancing it. Again, your initial blood pressure comes up to be handy. And in those poor grade patients, I will say don't reduce it to a mean less than 70 to 75 in these patients, poor grade patients. In a good grade patients, you can decrease the transmural pressure for a while. It doesn't make a difference, much of a difference. Okay, so as regards what is the difference between a craniotomy or a coiling, in this the increase in mean arterial pressure apart from the intubation response, there is a femoral puncture, very less significant than a skin incision, and sometimes the neurointervention is just extend the head for assessing the ACOM's aneurysms. So at that time your muscle relaxant effect might be wearing off, so you just see a sudden rise in, sometimes they actually flex the neck as well. So it depends what kind of a neck position they are doing, and at the time of neck positioning your blood pressure might swing up. And sometimes when you put an endotracheal tube and you're taking the tube on the left side, at that time also there's a blood pressure swing. So take these tits and bits needs to be taken care of. Okay, so the most important goal at that time is smooth induction to avoid hypertensive response, and you can use any sort of anesthesia. There is nothing that this is preferred or that is preferred. So you can use fentanyl, propofol and rocuronium per se for giving anesthesia to these patients. That's perfectly fine. And you can give a bolus dose of lidocaine, propofol bolus to decrease the transmural pressures. Okay, should we hyperventilate or not at the time of induction? That's actually another very important goal, but doesn't make a difference whether you are going for a clipping or coiling. Again, it depends whether your patient is a good grade aneurysm or a poor grade patient. If the patient is poor grade, you can slightly go for hyperventilation, but if your patient is a good grade patient and you hyperventilates, then actually your transmural pressure will rise and there are every chances of rupture. In a poor grade patient, the ICP is actually been on a higher side, so little bit decrement on the ICP by giving in hyperventilation doesn't make a difference. So in a poor grade patient, you can go for slight hyperventilation, and in a good grade patients, it's the other way around. So that's what we have discussed as of now. It doesn't make a difference whether your patient is going for clipping or coiling, but it's the grade of the patient which is going to make a difference at the time of induction. Okay, but A line needs to be taken. Good IV cannulas should be need to be taken. Whichever way of anesthesia you can use, we generally use inhalational anesthesia technique is preferred. I already told you that technically it seems to be easier. So monitoring, you see the arterial line is there. Whether you want to put it pre-laryngoscopy, so you can do that. Just give a dose of fentanyl and propofol. Once the patient has been induced, so if you have two people there, one of you can go ahead and put an arterial line. So it's always good to have an invasive BP, but I generally don't do it before inducing the patient, before giving the anesthesia to these patients. Okay, because sometimes your residents are putting it and sometimes they want to take time putting an arterial line. So it's always good that anesthesia has been induced and then they are putting those arterial lines. Okay. As regards central venous catheter, I will say in craniotomies we are used to put here also, but there is one difference here with craniotomies. In craniotomies we are used to put CVP lines, but in coiling I have stopped putting central venous line unless and until the patient is poor grade. I know the patient has come to me on a 4th or 5th day. I know this patient is going to have a high chances of cerebral vasospasm. This patient might require a post-op ventilation. In those case scenario, I do put a central line. Otherwise, with good 2 IV cannulas, I will generally able to maintain those intraoperative complications as well. God forbid if that happens. So there is guidelines also don't recommend to put it routinely. But if you are in a habit of putting it, no harm in putting it as well. But generally it's not good that you put it one day and then going to remove it other day. So it depends daily on your practice. So our practice is not to put it routinely. So come to the complications. So this is I will say the most important and dreaded complication. I will say the most important and dreaded complication is just hold for a while. I will say the most important and dreaded complications as regards the aneurysm coiling is intraoperative rupture of aneurysm. So if you see this slide, this is aneurysm, and when they are this is the coil which is going in. If they have started putting this coil inside the aneurysm and this coil loop goes out, you see this extravasation of dye. This is the extravasation of dye. So and you see this post-op CT, you can see this hemorrhage as well. So and this is one more picture. We'll discuss it. We'll just see those angiogram beautiful pictures which I have got for you. So if you look, this is also a broad neck aneurysm. Okay, so this is showing a road map. So road map is like when whole of the vessels looks white and your catheter looks black. So it is very easy to navigate and easy to know where your catheter is going in those road maps. Road maps are the thing when they are then putting the coil. Once they put a coil, then they take a angio picture to know whether the coil has been properly placed or not. So if you see that the tip, if you see this tip is actually been out of the aneurysm. So this tip of the coil is actually outside the confines of the aneurysm, but slowly and steadily they just put those coils here, and they completely occluded the aneurysm with adequate packing, and this patient actually goes home without any significant problem. So I will say, how will you diagnose it? So most of the time the radiologist tells you if there is an extravasation of dye, but if the radiologist is working at the time of roadmap, he is not able to know whether the dye has been extravasated or not. So there will be a hypertension or bradycardia if there is a bleed associated with that, and if you are using bis will actually drop. There might be a so these kind of changes you can actually tell the radiologist that this is what has been happened. So hypertension, bradycardia, arrhythmia, and blown out pupil. Radiologically, I will already told you the contrast dye extravasation. Or sometimes you can see that the coil loop is out, so they know that there is some problem with that. That they take a run immediately after that. So these are various monitoring exercise. TCD intraoperatively not much of a use, but if you are monitoring ICP, your patient is on EVD, you can put that EVD, if EVD is closed, you can put that EVD on a monitoring mode. You can see that there is a sudden rise in ICP and the presence of pathological waves as well at that time, and you can open the EVD, which helps in your management greatly at that time. So if you are monitoring those evoked potentials, so you can see a drop in amplitude and increase in latency. As you are monitoring SgVO2, there is a certain drop in values. So this is how you are able to monitor these patients. But don't panic. I will say if there is a complication, don't panic. So a cool anesthetist is the best anesthetist. So because you have to not only control those hemodynamics, you need to control the neurointervention environment as well. You need to control the patient and the radiologist, and then sometimes now there are various people into the neurointervention. You see a breed of neurosurgeons doing neurointervention. You see neurologists doing neurointerventions. You are seeing neuroradiologists doing neurointerventions. So they are also in a fix at that time. So the atmosphere needs to be cool. If there is a rupture, the coiling actually goes on, so that if there is a balloon already in situ, nowadays most of the people actually use a main balloon in the main vessel. So they just inflate it and then just fill the aneurysms with the coil at that moment. So you need to reverse. So that's the most important step when it difference between the craniotomy and the coiling. So if you look at the craniotomy, in the craniotomy, no heparin is used, of course. So the first step out here is to reverse the heparin, whatever you have given in last 2 hours. Just reverse it with protamine, and we all know the dose of protamine which needs to be used. So, and I will say decrease the bleeding by lowering blood pressure. But this is not a surgical field where you need to assist the surgeon by decreasing the blood pressure. So you just need to maintain that blood pressure, so that actually the cerebral perfusion is maintained at those critical care time. So use osmotic diuretics to decrease the ICP further, but don't decrease the blood pressure too much. But sometimes it is out of your control. If your EVD is already in situ in these patients, I will say your life is much easier. But otherwise, sometimes you require a ventriculostomy or an EVD, and you call a surgeon there and then. And if the patient is really in a bad shape, then you need to shift the patient for a decompressive craniotomy, and a clipping sometimes is required. But at that time, the fate of the patient is actually very, very poor. But what I have seen in recent times, if God forbid there is a rupture, the rupture rate has been decreased significantly over past 12 years. So I am from 2005, I will say, when I am doing neurointervention in AIMS, now in next 15 years holding those neurointerventions labs, I have seen that the rupture rate has actually been decreased tremendously, and even if it is rupture, it is better controlled now with those balloons, those good coils. So it is better controlled now. The second important complication, as I have discussed, is the thromboembolic complication. Now this is the complication which you are actually going to have more often now, rather than the hemorrhagic complications. So basically there is a clot in the vessel, okay, vessel base, and sometimes there is a major thromboembolism in the artery. So and you are going to find this, why I am saying that you are going to find this more often is because now in the era of stent assisted coiling, balloon assisted coiling, so those thrombogenic materials are more in the vessels, so those clot formation has actually been there in these vessels. So if you look at this case, if you look at this aneurysm, you look at this coil mass and you see, so what you needs to be done in these case scenarios, so your blood pressure. So I always tell that that's the importance you need to give to the blood pressure. You have to increase the blood pressure because you need to maintain the collaterals. So as soon as you increase the blood pressure in these patients, and then you see that this is what has happened in these patients, your vessels actually being opened up all over the things. You just have a mean blood pressure of 80 and now a mean blood pressure of 110, and at the same time I will say you increase heparinization, so you increase the ACT at the same time. That's what you are doing, and that what they are doing, they are injecting the intra-arterial platelets. Okay, so apiximab or aptia favitate. So this is a glycoprotein 2B 3A receptor inhibitors. So that is available to use intravenously or intra-arterially. So most commonly in our setup, this apiximab has been used as a RioPro, and sometimes if they think that there is a small embolism here and there, they use intravenously post-operatively as well. But with these patients, they generally lose the sheath, the sheath, femoral sheath. They left those sheath in C2 and they remove it afterwards, and sometimes they use a closure device. So you need to have a watch post-operatively on those puncture site as well. And there are chances of having a retroperitoneal hematoma in these cases as well. So you need to be extra cautious at those times. And if we say recovery from anesthesia, no different from craniotomy. So good grade patients generally being extubated in DSA Lab. I already discussed that you need to warm those patients and extubate in ICU if the patient is too cold. And based on intraoperative events, elective ventilation, neuro ICU. So these are the things. Those poor grade patients need elective ventilation. Poor grade patient needs to be extubated in ICU. And if there is an intraoperative event, obviously they are going to be extubated and seeing the post-operative course in the ICU. So once the aneurysm has been coiled, the second important thing and the second important problem which you are going to face is cerebral vasospasm. Cerebral vasospasm is the most important complication of cerebral aneurysm which you are going to face post-operatively in the ICU. But why I am tackling that, I am not going to tackle how you diagnose the cerebral vasospasm. Generally we do a transcranial Dopplers and serial neurological monitoring to diagnose cerebral vasospasm, but I am not going into the details of that. But if your patient develop a focal neurological deficit, you shift the patient to a DSA Lab and you do an angioplasty. So most of the centers, Western centers, are doing a balloon angioplasty. So they just do a proximal vessel balloon dilatation and the flow increases distally where you do a dilatation. But in our center, we generally do a chemical angioplasty with putting some drugs which are the vasodilators. So we put a nimodipine and a milrinone in each arterial territory, and if you look at the dose, nimodipine generally has been used as 3 mg in every territory, and milrinone has been used. So here also very most important thing is the use of vasopressors. So whenever you are giving those high doses of vasodilators intra-arterially, and then milrinone has been there intravenously as well post-operatively in these patients, so those patients generally developed hypotension, and this hypotension is actually been severe, so that requires a very high dose of vasopressors, I will say. And don't afraid to use those high dose of vasopressors. Sometimes I put those patients on noradrenaline and vasopressors as well, but slowly and steadily we know these drugs wean off from the system, and these vasopressors also be weaned off very quickly. So we all know that it's a complications which has developed. Now it has been dilated, the focal neurological deficit has been reversed, so we have to prevent the patient from cerebral infarction. That is why we are doing that. So a short duration of vasopressor, no matter how high dose it is to be there, but certainly you can ask the surgeon to limit the dose if there is certain comorbid conditions, the cardiac comorbid conditions are there. So if you look at this, so you take this patient in a vasospasm, you see there is no MCA, ACH territory is also being vasospastic, and post dilatation you can see it's well formed arteries. Okay, so a word or two about flow diverter. I will say this is a recent things. I will say recent additions to the metals in the brain. So there have been different metals which has been added in the armory of neurointervention, and this is the latest toy in their hand. So the flow diverter has been used day in and day out. The problem is that the indications of using those flow diverters, especially in, I will say, in a subarachnoid hemorrhage, I will say a blister aneurysm is more common reason for using that. Sometimes a dissecting aneurysm, and most of the times it has been put on those patients which has been incidentally detected as an aneurysm, so an unruptured aneurysm, or sometimes when the aneurysm has been coiled or clipped previously, but a part of aneurysm is there. Now the patient comes for a check angiogram, and now you want to secure that part as well on a previously ruptured aneurysm. So in those cases you put a flow diverters. So the problem which you actually face with flow diverter is, so these are the types of flow diverter. I'm not going into the details. Mechanism of action of those flow diverters. So if you put a flow diverter across those arteries, there is a disruption of blood flow from the parent artery into the aneurysm, and there is a profusion of a scaffold on which the endothelial cells can actually grow. So these two actions actually isolate the aneurysm from the parent artery by causing a remodeling or reconstruction around the prosthesis, while eliminating the aneurysm parent vessel interface, altering flow dynamics both across and within the cerebral aneurysms. So you can see these are the flow diverters. So why are we worried when they are using those flow diverters? Why are we worried? So we are generally being worried in subarachnoid hemorrhage, those patients which they are dealing with a ruptured aneurysm and they are putting a flow diverter, because they are using antiplatelet drugs to maintain those patency of those flow diverters. So flow diverters are like stents only. So when they are using that, they are using dual antiplatelets. And most important thing is that aneurysm is not yet occluded. So once you put a flow diverter, it's not that the aneurysm is secured there and then. Aneurysm will take some time, sometimes weeks to be get secured. So that's the most important thing. You have done a procedure, but still your aneurysm is not secured. So it can still rupture. Patient now is on antiplatelets, and you are hoping that the flow is decreased in those aneurysm and it may not get bleeded in some weeks time. So blood pressure management, especially in subarachnoid hemorrhage, is the problem. But when you are putting it in unruptured aneurysms, then you can be more liberal with your blood pressure controls, and antiplatelet drugs are there, so there is every point to worry. Sometimes what you need to do is that you need to put those EVDs in those patients, subarachnoid hemorrhage patients. If they are planning to put a flow diverter, put an EVD before. But sometimes aneurysm ruptures intraoperatively, and then the patient was already been loaded with antiplatelets and they have put a flow diverter. So it's kind of a fix. So but when you are doing what our practice is, if they have a rupture and there is a flow diverter in situ, what we do, we generally give platelet transfusion, because according to recommendations as well, if there is an ICH or an SH, you are going to do a procedure, neurosurgical procedure, you can do that platelet transfusion. And once you do that procedure, then we start the patient on a single antiplatelet, and I think within 48 hours we generally take the patients on dual antiplatelets. So that's the kind of management which is actually being changes because of the devices which we are in. So flow diverter actually demands a full lecture, so I'm not going into the details, because there are many complications which happen because of flow diversions as well. But largely and literally they are safe procedures to do. More than 90% of the procedures it's I will say 90 more than 95% of the procedures have been done very successfully. So not major issues with that. So that's the main problem I will always focus with flow diverters, that aneurysm is still not occluded. Always remember that. So now leaving the aneurysm, so aneurysm done, with aneurysm the vasospasm complications done, then the antiplatelets and the flow diverters has been done. So now we come to AVM embolization. So AVM is another vascular procedure, and according to Spessler-Martin grading, that has been grade 1 and 2, grade 3, grade 4 and grade 5. I am not going into the details again, but generally these embolizations can be used as a definitive treatment or can be used as an adjunct to either surgery or radiation. In high flow intranidal fistula, balloon can be used to reduce the flow so that embolization can be done safely. Now actually endovascular AVM embolizations has been done with glue or onyx. So these are the two materials which actually been used most commonly. I have shown a coil as well. So coil has been used to actually for the intranidal fistula or intranidal aneurysms if it is there. But most of the time I will say that it has been done with glue and onyx, the AVM embolization. But what is the difference between these two agents? So glue is I will say basically a cyanoacrylate polymerizing adhesive, which actually solidifies. It solidifies when it comes in contact with ionizing solution like blood. But the onyx, it is basically an ethyl vinyl alcohol. It's a copolymer. It solidifies through precipitation. Okay, and it allows a controlled injection. So that's the main difference. So with onyx, they're able to give a more controlled injection and filling of vascular anomaly or that vascular territory. It is over several minutes. But with glue, it just in a fraction of a second. It's like that. So it can fly to various places. Sometimes on those places as well where you don't want them to do. But it is typically cheap, dead cheap in comparison to onyx. So that's the difference of the material which they are using, and they can cause problems like if they can fly to sometimes fly to pulmonary artery as well. So pulmonary embolism is significant problem in these cases as well. So you should be aware of those complications which can happen to it. So at the time during the AVM embolization, what you need to look at is that decrease heart rate and blood pressure to prevent flying of those glues and onyx material. There can be an allergic reaction to glue. Microcatheter can be entangled in the onyx. So at the time when they are actually retrieving those microcatheter, you need to reverse that heparin as well through protamine so that there is no bleeding, because it is sometimes they need a pull or I will say a jerk to remove that microcatheter. And post embolization, so the vascular territory where the AVM is basically in hypoperfused territory. So some normal pressure breakthrough bleeding, that is NPBB, which has been defined in the literature. So you need to decrease the blood pressure to around 20%. So again, blood pressure comes handy. I told you that blood pressure is your most important tool. You need, most of the time you are playing with those blood pressures. So that you need to remember, you need to decrease the blood pressure significantly post embolization. And do not forget to load those patients with anti-epileptics. These patients are already on anti-epileptic because most of the AVMs have been ruptured and then come for treatment. In case of spinal AVM embolizations, your upper limb is positioned like this. So you need to maintain those IV cannulas and extension lines accordingly. And it requires repeated apnea. So even the angiograms, the spinal angiograms have been done under general anesthesia, because they require the frequent apneas on those patients. So as regards complication, if you look, this is a CT scan which shows a hematoma in the left region with an IVH. Okay, this is an AP view, and these are the lateral views of angiograms, and it reveals an AVM in the left temporoparietal occipital region, and there is a left PCA draining via large vein into the straight sinus. So the most dreaded complication for them is when the draining vein is occluded. As soon as the draining vein is occluded through glue or embolization, there is a venous edema. So that's the main problem with those. So if you look at this microcatheter injection showing AVM nidus glue cast, this is the glue cast with inadequate penetration into the nidus. But then they place a second microcatheter and then they put more glue, and then they can see that that the glue has been gone into the straight sinus, so that sometimes have a catastrophe in these patients. You need to decrease those blood pressure in those cases. Okay, so normal pressure breakthrough bleeding, going to glue or onyx, going into those unwarranted territories which they can go, so decreasing the blood pressure at that time. And sometimes you have to increase the PEEP so that it doesn't go into the pulmonary vessels. So these are your most important goals. When you extubate, extubation also with an AVM embolization had to be on a lower blood pressure. So you put the patients on those labetalol infusions if the patient is already in bradycardia. Use and titrate those drugs with smaller dose of NTG, though NTG in most of the literature has not been recommended to decrease the blood pressure in neuro cases because it increases the cerebral edema. But sometimes you can use it for a shorter duration, because post-operatively you can always put those patients on antihypertensives, and because of the vasogenic edema, sometimes these vascular anomalies can cause AVMs. I will say this, they are still very fond of using steroids in these cases. And always remember, if the patient actually complains of headache post-operatively, so that may be an indicative of an ICH or a bleeding. So from this vascular procedure, we move to thrombotic complications, those vascular procedure which are actually causing strokes. So carotid stenting is the procedure which actually been done in MAC, and the reason for doing that in MAC is that you can actually know it's a short procedure. You just need to put a stent in the carotids, the ICA, and you are able to neurologically monitor the patient there and then on the table for any stroke which can happen in those patients. So the most of the time the patient doesn't require anything. The anesthesia is on a standby mode. Sometimes if the patients require something, you can give a smaller dose of fentanyl or midazolam, smart acting agents in these case scenarios. But the most important problems is nowadays is that you need to monitor and you need to see those red flags in the pre-anesthetic checkup of these patients. So if the patient has got a diabetes mellitus, long-standing hypertension, stroke, recent or contralateral carotid endarterectomy already been done, there is a high-grade carotid artery stenosis, and there is an impaired VMR, that is vasomotor reactivity, which you can actually detect through transcranial Doppler. So this we have actually been included in our pre-anesthetic checkup. Every patient who is going for carotid artery stenting, we do a transcranial Doppler in the preoperative checkup. So we know the baseline velocities which the patient is having, and also whether the VMR is preserved in those patients or not. Because if the VMR are not preserved in these patients, then there are more chances that if the blood pressure is increased in these patients, there is a chance of hyperperfusion bleeds. So again, the blood pressure comes handy to you. So these are the red flags in the pre-anesthetic checkup. The red flags for what? Red flags for having a chances of developing a hyperperfusion syndrome post-operatively, or I will say post-revascularization. If you wanted to go into the detail of hyperperfusion syndrome post-carotid revascularization, I recently published an article, review article in Journal of Neuroanesthesia and Critical Care, last edition. So you can look at that edition and go into details of hyperperfusion syndrome. So now I come to the management of the complications in carotid artery stenting. So most importantly, when they're manipulating those balloons and putting those stents, and especially when they are dilating after putting those stents, there is a bradycardia and hypotension. Usually it responds to a dose of atropine. Sometimes when it doesn't respond, you need a temporary venous pacemaker. So if you have pads, it's well and good, attach those pads. If you don't have those pads, sometimes in critical stenosis, you need to put those pacemaker as quickly as possible. So it might be required in these patients. Another most important related complication is stroke in these patients. So use distal protection devices during carotid artery stenting, and maintain adequate map for collateral perfusion if God forbid there is a stroke. But most of the time they use actually those filters, so that any embolus should be trapped in those devices. And sometimes hypotension and bradycardia, when it suddenly happens, it already compromised in an already compromised brain, it causes cerebral ischemia and seizures at that time. But generally it just respond to their balloon deflation. So patient suddenly wakes up and say that's all fine. So these are the things which happen on table. So just because it's happening in MAG, you should not be relaxed. You should be actually more vigilant. As far as stent thrombosis, intraarterial vasodilators, and blood pressure is the most important thing. In some of these patients, you have a cardiac complication as well, because it's not the atherosclerosis is only happening in the carotid vessels; it's there in the coronaries as well. So, as the cardiac reserves are very important to be tested in these patients, cardiac ischemia sometimes happen in these patients because of hypoperfusion and hypotension, post-op hypotension in these patients. So, if this patient complains of slightest of chest pain, slightest of jaw pain, any kind of a symptoms or any change in ECG if you are seeing, just inform the cardiologist there and then, because sometimes the DSA lab they require an angioplasty as well. Okay, now a word or two about hyperperfusion. I will say, I already told you that you need to look at the pre-operative transcranial Doppler in these patients, and post-operatively, if there are red flags in there, you need to maintain those high index of suspicion. We do post-operatively transcranial Doppler in these patients as well. If there is more than 100% increase in the post-operative velocities from the pre-operative velocities, we certainly go on and decrease the blood pressure almost 20 to 25% of the baseline in these patients to prevent those hyperperfusions. Generally, those hyperperfusions happen earlier in carotid stenting than in carotid endarterectomies. So, because in carotid stenting there is a balloon stretching of the baroreceptors. So most of the time it happens during the first week in carotid artery stenting, can happen in second week as well, but most of the time in carotid endarterectomy it happens in the second and third week of. So this is also a patient of carotid artery stenting. I am just giving you the angiogram picture so you know how it is there. So it is like, this is the carotid stenosis in these patients, then they just put a stent, and then there is a post-operative hyperperfusion syndrome bleed in these patients, there is an ICH. So we actually have formed a protocol in our unit. So I already told you that preoperative TCD has been done and VMR has been noted, baseline mean flow velocity has been noted, and if there is more than 100% increase in those velocities, then the stricter control of blood pressure in the first week is warranted. So I am not going into the details. Now I come to one most important thing, and the one of the most I will say the emergency. SAH is also an emergency, and securing an aneurysm is also an emergency, but I will say this is an urgency. You have to do it there and then. And with the diffuse and dawn trial coming in, the mechanical thrombectomy, the window has been extended up to 24 hours, as you all know. And the mainstay of the treatment still remains TPA, the IV TPA, which needs to be given in 3 to 4.5 hours depending on the patient. But important is that this is a real emergency in DSA lab, and your DSA lab is not prepared, then you are in a mess. So everyone should know what to do, how to proceed in a mechanical thrombectomy. That's the baseline. You all should know the protocol, what to do in a mechanical thrombectomy. You can't go and decide. So why we are debating, why it's so important? So there has been enough articles whether we should go for a general anesthesia or a conscious sedation in mechanical thrombectomy. There are some pros for general anesthesia, like there is no patient movement, good quality of imaging, there is an airway secured, and there are some cons as well, like hypotension, which is the main culprit, which has been posted in various studies. then there is a time delay, and there are sometimes setup issues and resources as well. As far as conscious sedation is concerned, neurological monitoring is easy, stable hemodynamics, no delay till groin puncture. But I will say, if you're doing it in local without giving any sedation, then it is okay. Conscious sedation, you are using anesthetics, a continuous anesthetics to maintain that, then I will say you can go for GA if the patient requires. So most important thing is, if the patient requires general anesthesia, patient should get a general anesthesia. That is my take on it. But why there is a problem? So general anesthesia was labeled as bad. It is bad in all the previous studies in 2016, that you should not use general anesthesia, it is going to affect the outcomes. But these all studies were retrospective. So these are several retrospective studies. If you go into the literature, there are several meta-analysis as well. Though several retrospective studies have been published and show that it has got a better neurological outcome after conscious sedation. So but there has been no difference between good neurological outcomes. So what I mean to say is that all retrospective studies says that there is a bad outcome. So if you look at this retrospective study, there is a worse outcome after endovascular thrombectomy were associated with GA. And if you look at this one, which is published in Stroke in 2017, this meta-analysis, it shows that acute ischemic stroke undergoing intra-arterial therapy, worse outcome when treated with GA. So these are this is a meta-analysis, the Chinese meta-analysis, which is published in 2016, 2018 only, recently. So it is also causing that acute ischemic stroke with GA is bad. But the problem with all these studies is that there was a bias involved in that. So GA group have got a higher NIHS score. GA group have more patients with posterior circulation strokes. Okay, and most studies did not report protocols or details of what did they have used in general anesthesia, what are the drugs they have used in general anesthesia. They haven't given look into the factors like intraoperative blood pressure, blood glucose, respiratory variables. Also, a difference in the pre-stent retriever and the post-stent retriever era is there. But then, as it said that so sunar ki ek luhar ki, but there is I will say 3 luhar ki. So it's like 3 randomized controlled trials come one after the other. There is one is siesta, another is N-stroke, and another is a Goliath. And I will just have the conclusions of all of the 3. So in the siesta, the study findings actually do not support an advantage for the use of conscious sedation. If you look at N-stroke trial, it does not support the sole use of one anesthesia technique before the another, as long as a severe hypotension is avoided. Goliath, performing endovascular therapy under general anesthesia compared with conscious sedation does not result in worse tissue or clinical outcome when using a GA protocol, and the blood pressure limit has already been defined as 140. So they are saying that if you are able to maintain the blood pressure, then giving general anesthesia is not bad. So I know this, that hypotension is bad for the patient. Do I don't know this for subarachnoid hemorrhage? I already taken that in my first part of the lecture, that you have to maintain the blood pressure. From last 1 hour I am telling you that you have to maintain the blood pressure. So if you can maintain the blood pressure, then you can give general anesthesia to those patients of stroke. So how it is bad? I need to know that in ICH also I need to decrease the blood pressure. I don't need to go down beyond 140 in ICH patient as well. So when I know all those things, the important problem is if your anesthetist doesn't know about it, then it's a problem. But once all of you know about it, you know if your patient requires general anesthesia, what you need to do. As regards delay of treatment, if your lab is protocol has been fixed, I will say when you give a GA, the procedure is actually been done in a shorter time. So that has been shown in Goliath as well, and in N-stroke as well, that there is no difference in recanalization rate. So recanalization is actually the overall time taken for recanalization is no difference between conscious sedation and general anesthesia patients. Okay, so that is very important. And if you look at siesta, patient undergoing GA has a 10% higher recanalization rate as well. So I will say the patient is, if you require a general anesthesia, you should give it to them. So if you look at this study, there is one study previous as well, in which they say that general is better than local during endovascular procedure. That is a overall for general is better than the for all the endovascular procedure. It is not specific to mechanical thrombectomy because it's a study which has been done in 2010. So because general anesthesia, why they say the general anesthesia is better? Because general anesthesia allows them to perform interventions under optimal conditions, as I already stated. Fewer technical failures and complications occur and higher recanalization rates are achieved, resulting in better clinical outcomes. So, hypotension should be avoided. So, I am not going into the details. General anesthesia, okay. So, what are the limitations of these three RCTs? So, they are all the single center studies. They have relatively a smaller sample size and they have a high rate of conversion to general anesthesia in the non-GA group. In both CS10 and stroke, around 14% and 15% patients have been converted to non-GA to a GA group. There is a substantially higher than overall rate of 2.8 to 3.3% seen in meta-analysis, which in the previous meta-analysis there is a conversion rate of around 3%. In this, the rate is actually higher. So, how we do it? So, there is a pre-EVT workflow, how we label it, endovascular for endovascular thrombectomy. So, a person in neuro ICU in our unit is always available for mechanical thrombectomy to avoid any delay. Pre-anesthetic checkup should be done as quickly as possible. Just you need to ask about the fasting status of the patients. Aspiration is a major problem, but if the patient is fasting and the patient can sustain a local anesthesia, we will prefer giving a local anesthesia because aspiration is also a problem. As general versus conscious sedation, there is no particular choice. Practical sense prevails. General anesthesia in uncooperative patients, difficult anatomy. So, basically, as I have stated, those who require general anesthesia should get general anesthesia. So, job is to make interventionists get the perfect conditions and help in getting the recanalization. Blood pressure, systolic blood pressure more than 140, and if there is a good recanalization, then there is a chance of hyperperfusion bleed. If it's a partial recanalization, maintain it below 180. But if it is full recanalization, then 140 is a very good blood pressure because hyperperfusion bleed can happen in these patients as well. And sometimes in these patients, patient has already received an intravenous TP and then patient comes for mechanical thrombectomy. In those patients also the chances of hyperperfusion bleed is there. So again your blood pressure management comes handy. So, we generally maintain arterial blood pressure. I have already stated, if you do have a delay, take those femoral sheath and tell them not to remove those sheaths. Okay, for at least for 24 hours, or you change it to radial artery cannulation and then maintain it through that. So, management of anticoagulation, administer heparin throughout the procedure as requested. ACT should be maintained between 250 and 300. Blood sugar we maintain generally below 180 milligram per deciliters, and management of complication ICH, thromboembolic complications. So most of these complications, blood pressure management is the key. Hypotension should be aggressively treated. So there is one more complication I just wanted to highlight. There is one more complication which actually happens in our DSA lab, and it is the intra-arterial embolism of air. So it's air actually being pushed from the vascular catheter, and it was a posterior circulation aneurysm. So a massive intra-arterial embolism happened in this patient. So you look at this, the aneurysm was coiled actually, but there is a air in C2. If you look at this, and then we have to do a CPR. Actually, patient revived. We have aspirated through the air through microcatheter. They keep on aspirating and we keep on doing the CPR, and we maintain high heparinization in this patient, actually in this case scenario, and we use intra-arterial antiplatelets as well. And most of the time, it actually patient requires at that time a vasopressor, and because of higher heparinization, higher intra-arterial platelets, patient actually developed a retroperitoneal hematoma because of an hepatic artery branch bleed. We shift the patient to neuro ICU, and then we again shifted the patient back to DSA lab to stabilize that hepatic artery branch bleed. But we discharge later the patient in stable M6 condition. So sometimes there is a catastrophe in DSA lab and you need to get ready. So you are always ready when your protocol is ready. Perform the protocol, maintain a protocol so that your technicians should know the protocol, your DSA labs and staff should know the protocol, and once the protocol has been formed, you see that the life is much easier. So retroperitoneal hemorrhage, you should always have a high index of suspicion. Anemia and hematuria post-operatively, abdominal discomfort in extubated patients. Generally, it has been self-limited, but sometimes a vascular or surgical intervention is necessary. So, which I am speaking most importantly from the very beginning, it is nothing but fine management of blood pressure most of the time. So, there are n number of procedures like tumor embolization I have not touched, but it's not necessary to go into the details because it's like an AVM embolization. Most of the time you need not to worry about the blood pressure as well in those cases. There are some vascular angiomas in which you just increase the carbon dioxide so that vascular territory is dilated, so the glue should percolate in those vessels in which you are desired to go. So these are small procedures. And another thing which we have recently been doing is intra-arterial chemotherapy for children of retinoblastoma. That is also a short procedure, but because the children are involved, it's an OPD procedure and daycare procedure in which we are doing. But nothing specific apart from the pediatric anesthesia has been there. There is a special consideration which is given to vein of Galen children, in which the patients actually been in CHF, and those patients actually require special consideration on those times. But generally been there is a special, I will say, a special class for vein of Galen malformation, because it's going to take another 45 minutes to 1 hour. So I will say thank you, and thank you for giving me this opportunity to teach them. Just tell me whether you want anything more in this. I will keep recording and send it to you again. Thank you very much.